So the impact, of course, is, again, more Indians with insurance, so we need that. So I'm going to give you a little picture about how all this stuff works, because a lot of times, you know, we think, oh, we're going to go down there to the DHS office and we're going to roll a Medicaid, but you don't even know where. It's like a black box. You don't even know where it comes from, right? It's just the office down the street. So I'm going to kind of break down how all this works and how it fits within the context of you as American Indian people that have a federal trust responsibility for health care, no matter where you live. So U.S. Congress, you know, the treaties that were signed between tribes was with the federal government. So that's why tribes have a sovereign nation. They're as sovereign nations. They have a government-to-government relationship with the federal government, not with the states, with the federal government. And so those treaties were signed, which actually allowed us to develop the Indian Health Service. So the Indian Health Service used to be under the Bureau of Indian Affairs, but a long time ago. But it really didn't make sense under the Bureau of Indian Affairs. So in the 70s, they moved, they created this new department called the Indian Health Service at the national level, and they put it under the Department of Health and Human Services, so that now they were in their family of health experts. So they developed the Indian Health Services, and this Indian Health Services at the federal level directly funds either they run the services themselves for the direct service tribes, so those tribes that say, you know what, IHS, just run the service. We don't want to take it over. IHS, you just do it. So then they give money, they use that money that comes from Congress, it's allocated by Congress, to run services in tribes, for tribes. Then there are the tribes who say, you know what, IHS under self-determination, because we now as sovereign nations, we have self-determination as part of the Self-Determination Act that was passed in the 1970s. The tribes could say, you know what, we want to take over those services. So we're going to take our share of money, we're going to compact or contract with the IHS, and we're going to run it ourselves. So some of the money goes to tribes. And then you see this little sliver, well, this is the urban Indian health programs. So in that, part of the Indian Health Improvement Act, when it was passed, they started funding the Title V programs because of that relocation program, and they, you know, forced all those Indian people into the cities, and then they had no health care services there. So that's what this clinic is for, and what the other urban Indian clinics around the country are for. So here's the money that comes from IHS, and historically, a lot of our communities have just relied on the IHS for health care. And we never really thought anything outside of this little piece right here. But there's all these other opportunities to get money for health services within our communities. And so one of the things that you do is you guys got a Circle of Care grant. That's what this advisory council was pulled together for, right? So you got a Circle of Care grant. Well, that's funded under SAMHSA, which is also under the Department of Health and Human Services. So this is the Substance Abuse and Mental Health Services Administration. But this clinic could apply for grants from all kinds of agencies. And there's like, I don't know, like 12 different agencies under, I don't know the exact number. There's a lot of agencies under the Department of Health and Human Services. So there's a lot of different grant opportunities that you can actually apply for as an I, a T, or a U. And the other thing is right here, this is the Medicaid thing. So remember I said under the Affordable Care Act, there's going to be all these really cool things to get people insurance, whether it be Medicaid or the state exchange. Well, what happens is, let's say you come here to the urban clinic, you've got Medicaid, the clinic here provides you services, maybe for, you know, maybe you're doing your well checkup or whatever. So the clinic provides a service, and then they get to bill the state for the service. They'll bill the state of Michigan. The state of Michigan bills the Feds, the CMS, Center for Medicaid and Medicare Services, and then the federal government passes that money back through. So the state gets reimbursed for that. And so that's how that program works. So every time you come in, if a family comes in and they have a payer source, then that's bringing more resources into the community. So that's why if you're eligible for an insurance, being on one is really important for the clinics. For the whole ITU system, if you're going home to your tribe for services, it's important for your tribe, and it's important for all of the families in your community because you're bringing in resources and dollars to your community. And then the other thing is that now we can also bill for private insurance. So if somebody is employed, an employed Native person that has a job that actually pays them insurance, then they can actually bill for that private insurance. So those are some of the ways in which, that's how the money flows, and some of the ways in which the clinic here can get resources to support. So there's some other protections in the law. For those of you who are on Medicare Part D, there's this thing called a donut hole. And I was trying to think, I don't know what a donut hole is, and is that good or bad? Because I sure like donuts. The way that it works is this, is that if you are on Medicare Part D, then you and Medicare share the costs of your prescriptions up to a certain point. But when you reach that point, Medicare just stops paying. And it's all out of pocket, and it's all on the elders to pay for. And that is really, really costly to have to pay for prescriptions without any support. So the Affordable Care Act is working to close that donut hole. So if you're in the middle of the hole, that's not good. That's where Medicare is not paying anything, and you're paying 100% of the costs. So under the Affordable Care Act, what happens is once you reach that donut hole, you will get a 50% discount on any brand name drug that you buy. So if you buy a brand name drug, the pharmaceutical company gives that elder that's on Medicare Part D a 50% discount on the medications. If you get a generic, it's only a 7% discount. But there are discounts available for that. The other thing that they did is they have changed it so now there are no copays for prevention services like diabetes screenings, mammograms, flu shots, and some of those kinds of things. Because this year, even in the state of Michigan, there were a lot of Medicare beneficiaries that got a $250 rebate on their taxes, because for those that were in the donut hole. So if you were in the donut hole and you were on Medicare, you got a tax rebate of $250 in your taxes this year. So that's one of the things they did to try to fix it for folks. But this is in effect now. So this is a good thing. Like if anybody is, getting close to the donut hole, hopefully there'll be a little bit of relief for you. Other important protections in the law for those with private health insurance. Here's some really cool things that they fix. So one of the things that the law does is it tries to stop insurance fraud. And boy, there's a lot of unfortunate things that insurance companies were doing to people, and it stops that. And one of the things that it is now in law is the insurance companies cannot do any lifetime maximum benefits anymore. Because they used to say, oh, we'll only pay this lifetime maximum benefit and then we're done. We're not going to pay any more. If you get sick, then it doesn't really matter. We're just done. The next thing is that you have no more annual maximum benefits. So sometimes they were saying, okay, we're only pay this much a year and then we're going to stop paying. Well, insurance companies can't do that anymore either. They also can't drop somebody because they're sick. And then the other thing is that there are no copays for preventative care anymore. So preventative care is something that we should be focusing on as an entire nation. Like we need to be focusing on prevention. Prevention is good medicine. And first, to ask somebody to pay a copay to get prevention is not helpful, because some people can't afford to get prevention. And we shouldn't be in a place where you have to pay to get prevention. Prevention, you shouldn't have to have that extra cost. So there's no more copays for preventative care. And finally, women pay the same as men. And that's not been the case. Women have been charged a lot more for insurance historically because we use more